talk, and I am coming to the luteal phase support in my next talk. So since the first formal description of LPD in 1949 as a possible cause of infertility and recurrent miscarriages by zones, innumerable investigations have been undertaken in an effort to verify its existence or to characterize its pathophysiology, diagnosis, and treatment. So what is the consensus? The consensus of the literature is that LPD does exist and that its cause is multifactorial. So what are the causes for luteal phase defect? Abnormal folliculogenesis, inadequate LH surge, inadequate secretion of progesterone by the corpus luteum, and aberrant end organ response by the endometrium. But does you have to support luteal phase in cases of natural cycle? The answer is no. And what are the indications of natural cycle? Donor insemination, cervical factor infertility, mild or moderate male factor infertility. Here, luteal phase support will only increase the cost of the cycle without increasing your clinical pregnancy rate. Hence, luteal phase support in natural cycle is not recommended. So what we will be talking? Luteal phase support in the stimulated cycle. As what happens when you stimulate your cycles, the multiple follicles of different sizes might ovulate at different times, thereby expanding the fertilization window. Thereby, both estradiol and progesterone after multiple ovulation is expected to be slightly higher. And these high concentrations may not only influence the receptivity of the endometrium, but may also cause luteal insufficiency and early luteolysis. So therefore, if you are doing stimulated cycle, luteal phase support is must. And what are our options for luteal phase support? Vaginal progesterone, intramuscular progesterone, oral dydrogesterone, and HCG. When we are having vaginal progesterone, we have capsules, we have vaginal gel, and we have vaginal tablets. Whether you should give SCG as a luteal phase support, the answer is no. This was just to make the presentation complete. You don't have to give SCG as a luteal phase support. Progesterone, as I said, there are 3 routes: oral, intramuscular, or vaginal. This study I am quoting as this is a latest study published in 2020 comparing the dydrogesterone versus progesterone. As you all know, now many studies have proved that dydrogesterone is not inferior to progesterone. Nobody is saying equal or superior. It is non-inferior. So you can give safely dydrogesterone as a luteal phase support in your IUI cycles. When it comes to the progesterone, of course, our first choice is vaginal as compared to oral or intramuscular. Why? Because oral progesterone, they give you reduced implantation rate, in IUI reduced clinical pregnancy rate because of the poor bioavailability due to rapid hepatic metabolism and failure to induce uniform secretory changes in the endometrium. Also, the metabolites induce significant sedative and hypnotic effects. If you have seen, if you are giving oral progesterone, patient tells you that they feel dizzy and they feel sedated. So this is the problem with the oral progesterone. Vaginal progesterones are easy to administer. Avoid liver first pass metabolism. There are no systematic side effects. Higher endometrium tissue level despite low serum levels due to first uterine pass effect and similar pregnancy rate as compared to the intramuscular progesterone. However, vaginal progesterone, they do have little problem, that is vaginal discharge and perineal irritation. So if you counsel them well, they do accept the vaginal preparation and the vaginal progesterone. Intramuscular progesterones, previously we used to have oily based. They used to be very, very painful, and we never give oil based intramuscular progesterones. We are now having aqueous water based progesterone injections. They are not painful. Without any hesitation, you can give intramuscular progesterone provided she has a facility of taking those injections daily, because she has to take it daily. So you can prescribe intramuscular progesterone, but prescribe aqueous solutions. Dihydro, as I said, oral route, no sedative effect, non-inferior to your oral progesterone, has no androgenic effects on the fetus. So again, it is also very, very safe luteal phase support option. Now we also have an option of GnRH agonist as luteal phase support in IUI. So what are the regimens? If you want to use GnRH agonist, you can give single dose triptorelin 0.1 milligram 6 days after ovulation, or you can give 3 doses of lupride 1 milligram subcutaneous 6 days after ovulation. So this is the new thing which has come in the luteal phase support. Now this is the meta-analysis which says that if you are doing like natural cycle, so don't need luteal phase support. But if it is only oral ovulations, then also you can skip luteal phase support. But this is theoretical side. Practically, we all are giving luteal phase support, whether it's a CC cycle, letrozole cycle also. Gonadotropins, luteal phase support is strictly a must. Now you have started luteal phase support, when will you stop it? So when you can stop your luteal phase support? You can stop at 7 weeks of pregnancy. You can stop at 14 weeks of pregnancy. You can stop when you see your test is positive. In IVF pregnancy, we continue up to 14 weeks of pregnancy because we don't want to take that risk of miscarriage. But in IUI, once you document the fetal heart, that is at 7 to 8 weeks, you can safely stop your luteal phase support.